Panic disorder by Ashlyn Moore. Panic disorder is characterized by the appearance of spontaneous panic attacks, defined as discrete episodes of intense fear or discomfort, together with symptoms such as dizziness, tachycardia, sweating, and tingling sensations, and cognitive symptoms such as fear of losing control or feeling of dying. Patients with panic disorder experience recurrent unexpected panic attacks, are persistently worried about having more panic attacks, or change their behavior in maladaptive ways because of the panic attacks. I interviewed an expert in this field with some questions in regards to panic disorder. I first asked, "How long do your panic attacks last?" With which she responded that some panic attacks can last about 30 minutes, and even after the physical panic attack is over, she says, quote, "I don't feel right mentally for at least a day or two." I then asked, "Can you describe to me the bodily sensations that you feel during a panic attack?" She described feelings of dizziness, numbness, shakiness, hyperventilating, and, quote, "the world seems like it's spinning." I then asked, "Can you describe to me how you feel psychologically during a panic attack?" With which she responded with, quote, "Nothing feels real. I can't focus on anything except the fear, the thoughts of losing control, which makes me panic even more." This shows that the common symptoms of derealization and the negative cognitive feedback loop are associated with panic disorder in real life. According to Hinton, in the second half of the 19th century, before the appearance of the concept of panic attacks came about, German doctors actually, without knowing it, described some of the symptoms of what we now know as panic attacks. The symptoms that they noted were dizziness, shortness of breath, a sense of warmth rising from the abdomen, and irritable weakness of the nerves, all of which still align with the common symptoms of panic attacks today. Sigmund Freud stated that certain acute symptoms, such as dizziness, cardiac activity disorders, sweating, tremors, shock, etc., are special forms of anxiety attacks. Freud then attempted to find a cause for this disorder, with which he said these symptoms must be regarded as direct toxic consequences of disturbed sexual chemical processes. Furthermore, in the United States, even as late as the 1950s, anxiety attacks, or what we now know as panic attacks, today were seen as a type of schizophrenia. So they were originally treated with antipsychotic drugs, like a schizophrenic would have been. However, this treatment did not work effectively for panic disorder. It actually wasn't until 1980 when the development of the third edition of the DSM criteria established the concept of panic disorder. With this new disorder in mind, relaxation and cognitive restructuring for stressful life events were recommended for treatment of panic disorder. Many others also presumed that pharmacopsychotherapy was necessary for the control of the panic. According to the DSM 5, in order to be diagnosed with panic disorder, there must be recurrent unexpected panic attacks and the worry about future panic attacks. A panic attack is defined as an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time four or more of a list of 13 physical and cognitive symptoms occur. Some of these symptoms include accelerated heart rate, sweating, trembling or shaking, shortness of breath, feeling of smothering or choking, chest pain or discomfort, feeling dizzy, unsteady, lightheadedness, or faint. Complicating the diagnosis of panic disorder is that common comorbidities interfere with accurate diagnoses. Evidence suggests that panic disorder usually occurs with at least one other psychiatric disorder, like agoraphobia, agoraphobic avoidance, major depression, or alcohol and other drug abuse. To dive a little deeper into the comorbidity of agoraphobia, according to the research of Bandelow, in around two-thirds of cases, the individuals with panic disorder develop agoraphobia, in which individuals fear certain situations because of their thoughts that escaping might be difficult or embarrassing when panic symptoms occur. These comorbid findings may be helpful in distinguishing each diagnosis and developing appropriate treatment plans. From a biological perspective, there are several neurotransmitter systems, including serotonin and glutamate, as well as CO2 sensitivity, which are possibly involved in the etiology of panic disorder. Also, the defense circuits of the brain feed back to the sensory systems, signaling the detection of threatening or potentially harmful stimuli, and therefore prompting defensive reflexive motor responses to counter these perceived threats, which, in the case of panic disorder, is reflected through panic attacks. From a psychological perspective, panic disorder is associated with a tendency to catastrophically misinterpret physical symptoms. So, when a perceived threat is presented, the neuroanatomical hypothesis presents the idea that there is a neurocognitive deficit in the sensory processing pathways, causing a catastrophic negative feedback loop in which there's a misinterpretation of anxiety provoking stimuli, which in turn activates the fear network in the brain and causes these intense panic attacks. To further these points, according to the research of Pilecki, he also sought to answer the question of how do panic symptoms develop. He argued that sensations are misinterpreted in the brain as a greater threat than they actually are. This thereby perpetuates the fear response mechanisms and leads to ever increasing physical sensations, which take the form of a panic attack. After experiencing one panic attack, an individual may learn to be even more fearful of these bodily sensations and develop an even greater fear of external triggers, thereby making additional panic attacks more likely to occur. Though some individuals may not develop panic disorder after the occurrence of a single panic attack, it is shown through research that those who maintain catastrophic cognitions regarding their own physical sensations will be more likely to experience additional panic attacks. This catastrophic negative feedback loop in the brain is one of the hallmark symptoms of panic disorder, and it is why it is so difficult to overcome, because in order to overcome this negative feedback loop, one must completely alter their cognitions regarding the panic attack. This is also one reason as to why anxiety sensitivity has been linked to individuals who have experienced panic attacks. There are also some psychosocial contributors and environmental risk factors to take into account. Gender plays a role in the etiology of panic disorder because women are more likely to endorse more individual panic related symptoms than men. Other possible contributors are childhood sexual abuse and chronic stressors in adult life, which may account for a higher prevalence of panic disorder in women. Psychological coping strategies involving relaxation training, cognitive behavioral therapy, and exposure therapy yielded the most consistent results in treating panic disorder. Cognitive behavioral therapy directly addresses the response patients have to the irrational thoughts of anxiety and panic, with a focus on replacement of negative cognitions with positive thoughts. Treatment is based on the theory that the patient develops a negative feedback loop by reacting and thinking negatively during a panic attack, thus reinforcing anxiety and panic. In cognitive behavioral therapy, patients are taught to recognize these catastrophic cognitions and replace such thinking with more realistic problem solving thoughts and strategies. In regards to exposure therapy, patients are taught to deal with the panic attack as it comes, and to remember that while experiencing a panic attack, they must tell themselves that it's just a bodily reaction and that they will make it through the panic attack, even if they do not feel like they will in that moment in time. Antidepressant medications and serotonin reuptake inhibitors have also successfully reduced the severity of panic symptoms and, in some cases, even eliminated panic attacks. For long-term treatment effectiveness, psychological treatments were proven to have lower relapse rates than pharmacological treatments. However, more research suggests that the overall best treatment options are cognitive behavioral therapy in combination with antidepressants to treat patients with panic disorder. Catastrophic agoraphobic cognitions were the strongest predictor of poor outcomes as far as prognosis is concerned for panic disorder. Strength of blood injury fears, age of initial onset of panic symptoms, comorbid social anxieties, and degree of agoraphobic avoidance were also significant predictive measures for the development of panic disorder. In most cases, if these are caught early enough, appropriate coping mechanisms can be learned and put into practice and defend against the development of panic disorder. From a biblical perspective, there are biblical-based counseling services to help treat panic disorder. One of these counseling services is Biblical Framework Counseling, or BFC for short, which is based on the belief that the Bible is adequate in treating root causes of mental disorders. Biblical Framework Counseling teaches their patients to strive to keep one's thoughts in harmony with God's promises and standards. Some may say that spiritual symptoms in relation to panic disorder may include a lack of trust in God, doubting His promises, or having a distorted view of God's love, control, or provision over your life. As the patient recognizes and trusts God's power and authority, finding peace is possible. In John 14:27, we are reminded that Jesus does not want our hearts to be troubled or fearful, so he promises peace that only he can provide. So, in order to attain this peace, we need to completely rely on him.